to understand where your target is located inside the chest. So just an example, this is the aortic valve. I drop my pointer here, I scroll, look for the sternum, so I see where the aortic valve is below the sternum. Very easy. So when I'm approaching the patient, I'm going to the patient's bed, I put him on the right position, I already know, maybe I start thinking, okay, I know the aortic valve is there, and I'm entering the chest from here. I'm in the right position. And then here, I see the radiologist here. Hi. So we had some time together yesterday. Then what I look at, what I want to see. Of course, forget about all the calcification of the aorta, the growing vessels, the size, the quality. I'm talking about where to enter the chest. So this is the first intercostal space, this is the second, this is the third. What I want to be is to be close and perpendicular to the aortic valve. So what I see here, this patient has a reasonable intercostal space, the width of the intercostal space, and the distance from the chest wall, to the aortic valve, that is in this patient is 12. When you are below 14, 15, it's going to be easy. You can do even beyond, but I think you have this problem. This valve was at 5 centimeters from the chest wall after we put the sutures. 5 centimeters. I see you can confirm. What I also see is the angulation of the aortic valve. At the beginning, you can do all of them, because when you open the aorta, I say it's like a banana, so it will look at you, it will look towards the chest wall. But the more horizontal, this is a TAVI wall, the aorta is, right? Probably the more perpendicular you will get the valve when you're operating on it. So at the beginning I was thinking maybe the vertical aorta, the valves that are looking up are good for anterior mini-thoracotomy, and the horizontal valves are better for transaxillary. It's not true. It's not true. I don't think it's true anymore. You can do everything from the transaxillary. What you also can see is you make your clamp. The clamp position is very important. So let's imagine you agree this is the transverse sinus, this is the left atrium, this is the pulmonary artery. So if you put your clamp here, where you normally put your clamp when doing mitral valve, so I drop the pointer, I scroll, you see, my clamp would be extremely low. I would have not sufficient aorta to open and to get access to the valve. My aortic clamp should go higher. I would say above the pulmonary artery, which is this one. So I drop the pointer there. This will be my clamp direction, and I like it because it will be out of the way, and it will give me something like, I can't read it, despite my glasses, maybe 6 centimeters of aorta to work inside. So I already see this will be the yellow line. This will be my working trajectory. With transaxillary mitral, you work endoscopic, it was like this. You work towards the left upper shoulder. Transaxillary, you work perpendicular or a little bit oriented towards the LV apex. And here you see if you will be comfortable on table or not, because this will be your working trajectory. Your clamp will be off the line, but you see you will find the right atrium here. So normally when we're doing aortic valves, we put the stay suture here, and that goes out of the chest to expose the non-coronary sinus. So what you see here is that you will have this kind of view. You will see the clamp won't be on the line. You understand that your aorta will be sufficiently long to work inside it. You can anticipate that your right atrium, you can put it out away. Also, you get other information, like another thing I think it's important. When you look at the CT scan and you're considering entering this intercostal space, what you want to see when you open the chest and when you open the pericardium is this part of the aorta and the tip of the right atrium. If that part is in front of the intercostal space, that is going to be 99% the right intercostal space. One more thing important to consider is how you make your CT scan. Most of patients are on the CT scan, they are with arms like this, up. So that's why for the aortic valve, we kept this position. We want to remain consistent with the position the patient have on a CT scan. Because when you pull up the heart, the cage goes up, while the sternum remains there. Something that you have to consider in mind. So arm down, cage goes down. Your space will be lower. Keep it in mind. And also you can get other information like the pulmonary vein. Everything is here. This is the mole. You see the pulmonary vein. You want to put the left vent here. This is nice. I leave the pointer there. I will certainly be in front of the pulmonary vein. It will be possible to put the left vent there. And then I have a rough information about how the aortic valve, very calcified, fibrotic like this one, small annulus, big annulus, small root. So here you get all the information to understand if your candidate is a good one for transaxillary AVR, and you can predict how will be your working positions, ergonomics, view when you're doing the operation. Of course, and I see here the radiologist, that this can be even more sophisticated, even more. Is this the one? Let me zoom out. You know, with here, can you see it? I can do better. With this kind of reconstruction that we had from the radiology department of the Bangalore Hospital here, it's even more, it's beautiful. First, second, third intercostal space. You see the pulmonary vein in front of you. You see the right atrium. You can understand same consideration. You can have the clamp here. This will be your view. The pulmonary vein will be right in front of you as the right atrium. So again, very easy, very nice to plan your operation on the CT scan. I think that was all. Thank you.